So there's been a lot of controversy and a lot of discussion recently about ACL repair versus reconstruction. Basically, the newest data says that despite all the hopes and the hypes about ACL repair, there's a higher failure rate. And especially if you're dealing with athletes, I think there's no shortcut, and we still have to do repairs, still have to do reconstructions in all of these. Otherwise, we're going to be confronted with a lot of disasters. So basically, repair, if you're dealing with athletes, don't consider it too much. You all know that we are in this area confronted also with a higher incidence of ACL failure. There's been a lot of research recently. We are doing this type of surgery, ACL with lateral tenodesis, quite often here in the area. I think that is a good thing. We started doing, or I participated in, a randomized controlled multi-center international trial on ACL plus or minus the lateral tenodesis, and I can tell you that recently, yesterday, we got the acceptance for publication, stating that there is a significantly reduced failure rate for ACL if you combine it with lateral tenodesis, especially if you're dealing with young athletes, soccer, pivoting sports, less than 25. Basically, there's an impressive reduction of the failure rate. This is the data. It's called the stability study. You will be able to read about it in the American Journal of Sports Medicine. But if you do an ACL in less than 25-year-old active high pivoting sporters, there's an 11% failure rate. If you combine those patients, randomized, controlled, multi-center, international, you reduce that failure rate to 4%. Very important. And then also, very recently, there's been some very interesting information about ACL. This is from our registry back in Antwerp. If you look into the effect of smoking, and I had a discussion yesterday with the football doctors, asking them how many of their patients actually smoke, and the answer was everybody. So if this is the case, this is a big opportunity, because I think what you see on this slide is that if you have an ACL, I'm not talking about ACL with monoloop, but if you have an ACL reconstruction, there's a 9% failure rate. If you do not smoke, it's only 3%. So that is 1/3 of those patients that will fail, or triple the amount if you smoke. And it's, I think, important and maybe an opportunity for an interventional study on the effect of smoking in this group of patients with ACL patients. So basically, if you want to have a good outcome with the ACL, I think pivoting sports, combine it with lateral tenodesis, and maybe it's time to quit smoking, especially in this area, and I invite you all to think about it. So back to the meniscus now. This is why I was here, why I was invited. I'm going to make some statements. Maybe they are a little bit controversial, but I think they're important. I think some of the knees and some of the athletes that we're dealing with are meant to have a meniscus injury. And if you understand that, or if you are okay with that, I think then if you want to do meniscus surgery and if you want to make a repair, then basically, since repair is weaker than the original tissue very often, then we are running into trouble. Being as good as before or weaker as before is just not good enough. So in other words, if the native meniscus was torn during sports and you want to go back to playing sports, most likely the repaired meniscus will also fail again. And this is very important to understand. It's very hard in soft tissues to be stronger than the original one. In bone, it works. If you break your bone, afterwards it's going to be stronger than before. In soft tissues, if you break it, it's never going to be as strong as before. That's why I think that we're still having the debate also in athletes that we still have resection versus repair, because resection is still a very good standard for a lot of these indications. And I will discuss them with you. On the one side, and on the one hand, you have downsides also of meniscectomy. In the short term, once in a while, you really have catastrophic events after partial meniscectomy, or actually after a significant injury to the meniscus that we treat by meniscectomy. I think it's still the injury, it's not always the surgeon. It's now a new hype to blame the surgeon for everything that goes wrong in life. But basically, it's most often the lesion. So if you have a catastrophic lesion on the lateral side, once in a while, you're going to be confronted with swelling, pain, rapid condylolysis, as you can see on the right. Those patients are really difficult to treat, and especially if they're athletes. So on the lateral side, go slow in your rehab and give some time to the knee to recover from the injury and from the surgery. On the long term, I think nobody disagrees with the fact that osteoarthritis is an event very likely to happen with all meniscus injuries and with all meniscus tears and with all surgeries in relation to a meniscus tear. Again, it's not the surgeon, it's actually the injury that leads, that has the effect on osteoarthritis. However, we can accelerate it with badly performed and badly indicated surgery. Biomechanically, it's very important to understand, especially again if you're dealing with athletes, that if there is an injury to the meniscus and you take it away, you're going to lose some stability in association, because that meniscus is a very important stabilizer in conjunction with the ACL. And it's in the AP direction on the medial side, and it's on the rotational direction in the lateral side. And so therefore there is truly an indication to repair as much as possible if the repair is successful, of course, but because if you're not successful and you repair and you have to go back in, especially in an athlete, it's always difficult because we're losing precious time to get them back to the field and to the pitch. So downsides of meniscectomy, basically yes, but there's also downsides on meniscus repair. We're not successful in every case. This is really very difficult. Meniscus repair is never as strong as the original one, in contrast to the bone healing, which I mentioned before. So there are some complications. I think we became better with the surgery recently. There's better tools, there are better surgical indications, but still there's some patients that will have joint line pain. There's still going to be failures, and we have to accept them. And it's just part of our life in dealing with athletes and dealing with patients. So basically, meniscus repair is not always as good also. And there's been a very recent and very nice paper by Rob Brophy from the US discussing all of these factors and taking them all into account: partial meniscectomy versus repair, reoperation rate. I don't see this as a negative side of meniscus surgery. I mean, I do accept, and in some we do a good job and then we have to go back into the knee to reoperate the patient. Some, however, see reoperation rate as really something very negative. But basically, if you look at the facts, a number of our patients will need reoperation after meniscus repair, while in the midterm, up to 10 years, reoperation for meniscectomy is a rare condition. So meniscectomy clearly has fewer reoperations than repair, and that also needs to be taken into consideration. So therefore, the last couple of years, because I had the reputation to be save the meniscus guy, but honestly on the medial side, and this is specifically on the medial side and specifically with athletes that want to return to sports, I think I have become way more selective in my medial repairs in athletes. So I'm doing a little bit more resections in some of these where I used to be pushing repair, but you are confronted with reality, and also with the smoking, because I think the same observations that we see with the ACL most likely are also a fact in every soft tissue repair, being it rotator cuff, meniscus repair, cartilage repair. So take that into consideration. My definite indications for repair, basically on the medial side, is everything that is very close to the capsula. And I will show you later on some slides where I think you need an MRI to see if you're close to the capsula, not just the preoperative arthroscopic image. I think that is also important. But so meniscocapsular and ramps. And to see these lesions, we need a different approach. You need to go through the notch behind the ACL and PCL and turn the camera and see if there's any lesion. If there's a lesion, and you can observe it in that position, as you can see here, these are not visualizations from the classic anteromedial or anterolateral portal. We really go and see in the back. If you see them in the back, I think those are really good indications for repair. And we didn't often use this type of approach in dealing and in visualization of meniscus injuries, but now we are doing this more on a consistent basis in these patients. Roots in athletes, which are a rather very rare lesion. And of course, I'm pushing it in young athletes. With young athletes, I mean not an established athlete. This is not an athlete that participates in the first team and is 25 or 27 years in the top of his career. These are the 16, 17-year-olds. Just, they have everything to make it, but then at a certain point, just before they make it to the first team, they have this injury. And in these patients, we have to have a different approach, because you want to safeguard that knee as long as possible. In the athletes that are established, you want to get them back as soon as possible to the pitch. And that's a difference that is really important to understand. But partial meniscectomy, basically on the medial side, is generally well tolerated in established athletes in the short term. So if you want to get them back to the sports and they're established, the number one of the team, then basically we're going to do a partial meniscectomy in a number of them, unless they are part of the definite indications. I'm going to share with you some of these typical surgical indications. This is a medial bucket handle. It's an isolated tear. So patient walks in, he's an athlete, he's established. This one is 31 years old, had a twisting injury 2 weeks ago with football, medial joint line pain, otherwise stable knee. What we used to do, and what you see in every book and every teaching document that you receive, and what we also teach to the young guys, is you're going to go in, you're going to have a look at the tissue quality, at the position, and then you'll decide if it's repairable, yes or no. This is what I was taught years ago, and that you still do. So if you look at this image, you see it's a large tear, it's peripheral on the image that you see, but you can't really see in the back. The back of the knee is really hard to get at, and so you estimate this tear to be really amenable for repair. However, if you take an MRI, and this is the MRI of the same patient, you will see, I don't know if we have a laser, you will see that the tear is peripheral. There's still a wall, and I'll show you just once again. So peripheral, wall present, big piece, big chunk, but you start seeing this horizontal fissure in the back. I don't know if you saw it. So there's something more than just a tear. If you go for the sagittal view, same thing. Then you see fissure, and you see a very big chunk still there. And actually, the big chunk is most likely larger than 3 or 4 millimeters away from the synovial tissue, and therefore, very often in these medial bucket handles, we thought that they were amenable for repair because what we saw was close to the synovial tissue and was close in the red-on-red area, the really well vascularized area. But in the back, which we underestimated very often, they were way more away from that healing capacity. And I think that explains why we are confronted very often in athletes or in normal people with a very good arthroscopic indication. But if you really look at the MRI, maybe that's not a very good indication, because in the back where it fails or where you often observe failure, it might not heal, because that's really white on white. And that's not in the books, this type of observation. And I think that explains why in some of these patients we are confronted with a higher failure rate than we would be comfortable with. This is the arthroscopic image. So I decided in this patient to take it out because there was a big chunk still in the back. It was horizontal. It was more degenerative. You don't rupture your medial meniscus just out of the blue. It most likely is weaker in some area. And so if you want to go back in this guy, you take out the diseased bit. And there's still enough in the back and here. So this is important, and I think this is real, and you can see that it's a little bit degenerative in the back. There's that horizontal fissure. So we decided to take it out. So now my indications are not just the arthroscopy. Basically, if I see the MRI, I will already be able to decide one is most likely to be sutured, the other one is most likely not to be sutured. And I decide more often not to suture than to suture on the medial side again. Same thing, medial bucket handle, isolated tear, 26-year-old. I just want to show you the MRI because it's important to understand and to have a view on the MRI. And luckily, we have a good MRI department here. They will guide you, but I can tell you very often the MRI reports are poor, and you need to look yourself to the indication and to the patient. So again, bucket handle tear, fragment tear, big wall. And if you look from in the sagittal view, that's the bucket handle part, but there's a big chunk here. And you don't see that. So I will, again, decide in this patient to do a resection rather than a repair, because in the back, this is white on white. This is nothing at all in the vascularized area. So preoperative, the imaging, I think basically what I'm seeing now is on the medial side. we overestimated the red-on-red area in a number of these cases during arthroscopy, which is considered golden standard. I think we need really to have the MRI as being the guideline for repairability of the meniscus and not so much the arthroscopy, especially on the back and on the sagittal images. And so that's, for me, a reason why my repair rates dropped and why I think we were confronted with higher than acceptable failure rates on the medial side. Medial ramps is something different. It's a different animal. This animal came into the picture maybe 5, 6 years ago. Before that, we weren't discussing this basically. And again, most of it is explained by the arthroscopy as being the guideline for treatment. And sometimes I think we miss this one. Ramp lesions are lesions really at the periphery of the meniscus, really at the capsula on the medial side, almost always associated with ACL injuries. Very important because they do have a biomechanical effect. And so there's been a number of publications, but all of them are less than 5 years old. So it's important to know this type of lesion. And they're almost always associated with ACL. And Bertrand Ricotet, one of the first authors to really look into this animal, to look into this pathology. And he noted quite a number of them that we didn't see on the MRI. But I think, again, it was the quality of the MRI that was really making him say this. Because if you have a good quality MRI, you will see this type of lesion. And you will have an indication to go in the back of the knee, because that's what we need to do. If you want to really diagnose this one, you have to go in the back of the knee. And I will show you why. So this is the tear, and it's very subtle. It's that fine line at the back between the capsula and the meniscus on the medial side. And there is an interface, there is a line to be seen. If you know that it is an ACL, really look into this pathology and have a look specifically on the medial meniscus. Again, a line. Once in a while, you're going to see a very subtle bone marrow edema, indicative of a crunching effect of that meniscus and some injury in that area. And sometimes the meniscus is torn and it's not the meniscocapsular transition, but it's actually the meniscus. But again, this is suturable. This is really nice, 2 millimeters away from the capsula. Perfect indication for repair. And another image showing you this. However, if you go into the knee and you don't have a look at the MRI and you go into the arthroscopy, I think you're going to miss it. Why? Because going in the back, especially in a knee with an ACL injury, already observing and looking into the back of the knee is very difficult. Getting there with your hook is very difficult. So touching and feeling the meniscus is rather difficult. And so you might miss this, and this is the explanation. So we've been missing this as an arthroscopist for a number of years. As an MRI specialist, we would have seen this earlier on. If you're really good and if you're successful and if the patient is a little bit lax and the medial compartment allows you to open it up, because sometimes you have the pivoting maneuver that happens during the arthroscopy, and then this area goes away all in the back. But very often you can see something at the undersurface. The upper surface is almost impossible to visualize, but the undersurface you will see that there is some damage. But if you feel and palpate the meniscus, it's still pretty stable. So on the superior surface, you can see that something happened. And this type of lesion has a massive effect on the AP stability of the knee joint. So this is repairable. The way we now doing it is we go from the back, and so we need specific tools, and so new tools have been developed. So this is the one. This is the actual lesion. This is the capsula. This is the meniscus. We go into in the back of the knee. We take a needle to introduce our knife, because this is an area where you don't like to go unless it's necessary. We now have specific tools. So you have the needle, you have the 11 blade that just follows my needle, you have the meniscus, you have the capsula, and you have the tear. So sometimes there's really big gapping, capsula, meniscus here all the way, and this is really the tear. And this indicates how big this gapping might be in the meniscus ramps. This is a new tool, and why is it so important? Because we're knee surgeons, we're not shoulder surgeons, honestly. So the shoulder surgeons, they have all these fine tools. The knee guys, most likely, were a little bit rougher. And so we identified and we discovered that we, and this is a surgical discussion, but we also need nice tools to do some of these fancy surgery. And this is one, it's a 2-barrel, it introduces a loop. Through that loop you can introduce and push a suture, and then you can really nicely take that piece out and you can make an easy suture. This is where you can see it happening. So we do this also in the surgery. This is that needle. In that needle is a loop. You just pick the needle. This is the meniscus. This is the lesion. This is the capsule. You go through. There it is. The needle comes out on the other side. You open up the loop. You introduce in that loop. You introduce a suture, and then basically what you do is just tie it. And this is easy. This is designed for a knee surgeon. That's how we are. This is easy, straightforward, very little complications with this. But this is new. Honestly, this is 2 years old, and it was invented by shoulder surgeons to help out the knee surgeons, and this is why I start liking shoulder surgeons. I'm making fun, of course. There's also something once in a while that you're going to see a young guy coming in with a very old knee. And this boy we saw, I think, on Monday coming into the office he was tall. He had a recent growth. He was taller than his dad, but he was clumsy. I mean, you know, the people in the audience that have 14-year-old kids, you know that they're a little bit clumsy, especially if they're grown recently. And so this kid comes in with a big tear on the medial side, out of the blue, playing soccer. And you can see here, what you observe is this is not a normal meniscus. You can see it's all gray, it's diseased, it's sick. There's a high water content. This is the MRI. Again, you will see how diseased this medial meniscus is. And so this is a challenge because on the one side, it's a non-established athlete. So if you take it out at the age of 14, honestly, he will never get to 25 without any complication. It's a massive tear. If you take that out, it's a massive piece. It will have biomechanical effects. So you want to repair this as good as possible, but it also implicates that that kid might not make it to the first team because of this injury. And it's the same thing with the ACLs. If you rupture your ACL at the age of 14, 15, 16, you might not make it. And this is an honest discussion that you need to have with your athletes, and most often with the parents, because the parents very often think the new Messi is born. If you have that type of lesion, I don't think that's going to happen. On the lateral side, it's different. I think I'm way less selective on the lateral side. Lateral meniscectomies, they shorten everybody's career, and this has been shown again by Rob Brophy independently. But there are very definite indications, full radial tears. This is a bad lesion. It's a catastrophe anyway. Better make it as good as possible with repair. Hypermobile lateral meniscus is a very neat indication for surgery. Lateral cysts also. These are all typical football lesions. And again, young athletes, we're going to push whatever we can in these young kids. These are these catastrophic lateral meniscus injuries, and this is a Red Devils knee. This guy didn't make it to the championships because of that lesion, and I'll show you a series of his knee because he came in with this type of lesion. And I can tell you, when I see this in an athlete, I'm getting really scared because you know this might be a career-ending lesion, and you know you're going to have to really be a good surgeon, but also be very lucky to get these back. They're not all winners, and that's something very frustrating. So if this would be preventable, I would go in way earlier. This guy had 3 injuries, 3 episodes of an injury, and ended up on the surgical table too late, I think. We should have gotten in earlier. So this is the reason in a number of these, and I just want to make you aware when we're dealing with athletes, in a number of occasions, the lateral meniscus tear starts with a very small injury and a very small tear. And then they make the same landing, the same jump a couple of months after the original event, and they have the same injury, and they feel a crack, and then you take an MRI, and it's just a little bit bigger, the tear. And then it happens a third time, and then it's completely torn, and it's a catastrophe. And you want to not end up with a catastrophic event, because then really we need to be very lucky. And it's all about crack propagation. If you're an engineer, you know that if there's a beam and there's a crack and you push on it, that crack will propagate and will cause more damage. So you want to stop that crack from propagating. That's basically what you want to do. And so very often these type of lesions never happen in a single event. Sometimes, or most often, they happen with multiple smaller events. It's very important to recognize that. This is that athlete that came in with this image, and I can tell you that's when you get scared, because you see a horizontal component, you see a vertical component, you see that it's almost all the way through. This is his MRI, coronal views. This is the axial view, really going, a lesion really going deep already in the lateral side. And you wished that this guy came in earlier, because I think if we were earlier, we might have prevented this, because you have an informed athlete, you have an informed staff, and basically with just a minor surgery, you can avoid crack propagation, I think. If you come in with this type of lesion, it's already really down the line, and you need a little bit of luck to go back to the game. You see the crack. This is the image original, the small image. But if you go back, you see that it really goes deeper and deeper and deeper, and it's important to understand this. So this is the lesion. You can already see that there's some cartilage wear. In soccer players, this is quite common. There's a flap. It's a complicated tear. There's the flap now, really going all the way in. There's still some rim, luckily, so we removed the flap. We contoured the whole meniscus, making it as good as possible. And then we did an open approach and had some sutures on the side. And I think that's what you need to do with this type of lesion. You have to make it as strong as possible, not just take pieces out, but you need to reinforce it to prevent further damage. And that's, I think, also key to better understand. So we contoured it, and then we did some suturing on the lateral side. And then you need a little bit of luck to get these back. But he came back very successful, so I'm happy for the guy. So lateral meniscus lesions. Again, crack propagation, tear propagation is, I think, a very good concept. I'm not saying that we need to address every crack and be now scared of a small crack, but you need to have some kind of awareness and some follow-up. Just at the end of the season, when I see these guys and they come in and there's a small crack, I will take an MRI basically in every player at the end of the season, just to make sure that there is no propagation. And if there's any propagation, I will promote now a little bit more aggressive approach with my indication for just a minor partial meniscectomy, round it, and make sure that crack doesn't propagate, rather than have a catastrophic event and a fully blown lateral meniscus in the office and a potential career-ending lesion. So medial meniscus, and I'm finishing on medial meniscus injuries and ACL intact knees. So the guy did something, and the guy or the girl did something, and the meniscus tore, meaning that at that level the meniscus is unable to withstand the forces upon that meniscus. So most of them I will resect, because that is a weak meniscus, unless it's really red on red, so the ramps, the roots, or if it's a young guy, and the roots. Because the meniscus in that specific knee is prone for injury, so he or she has something that makes that meniscus prone for the injury, and basically repair is not as strong as before. I'm not saying that if there was a stronger repair, and if we had tools and techniques that could really make it work, I would definitely repair. But basically what we see now with the tools that we have, with the sutures, with the augmented repairs, the PRPs, etc., very often we just don't get there, and it's still weaker than before. And it takes long. I think there's a lot of physios in the audience. You know that if you're dealing with a meniscus injury, it's always too long, and the guys really want to go back, and it's very often very frustrating. So most of the time, meniscus resection, very little downside, short and medium term, and watch out for hip stiffness in soccer players. Although I think in this area it's less obvious than, less common than in the Caucasian population. If it's on the medial side and it's associated with an ACL tear, with a reconstruction, again, same philosophy. However, sometimes I will push the indication for repair, knowing that my repaired meniscus, the fact that I have it in there, will protect and will allow my ACL graft to mature. And once my ACL graft is mature, which is basically 3 to 6 months, upon the slightest symptom of my repair of the medial meniscus, I will go back in, I will test it, and I might take it out. But at least I've given my knee, my ACL, 6 months to mature in a well-established, protected environment. And I have the impression that the ACLs do better if they have that meniscus. Definitely, they do better if the meniscus is present. But if you wait too long, then it's considered a reoperation for the patient. If you do this within the rehab phase, 6 months to 9 months after the ACL surgery, it's a different mentality. It's still in your rehab, and basically you take them, you slow them down by a couple of months, but it's not considered a reoperation for the patient. So this is still something where I think we will have some debates in the future and where we need more science. But this is my approach in a number of these patients. Lateral meniscus is different. Small tears, crack propagation, be aware. I hope I made you aware of this. We're going to repair whatever tear is there. And if you have to resect, please be respectful for the rim, because once the rim is gone, the knee is with a full loss of meniscus tissue, and therefore it's a catastrophe, definite, also in the short term. ACL tears and lateral meniscus, same thing. Same approach. So personal algorithm, lateral side is repair, medial side is repair in selective cases. But very often, a little bit more than 5 to 10 years ago, a little bit more resections. However, if you're dealing with athletes, I think players and also the management, the short term is they're established players. The short term is the only thing that matters for them. And I'm telling established athletes, if it's a young athlete with a future 10, 15, 20 years of a career still ahead of him, it's a different ball game, and it's a different type of athlete for me. So athletes, young athletes and established athletes makes a difference in my approach and in my story to the patients. But basically, meniscus resection, whatever we do, is always worse in the long term. So if you have still 10, 15, 20 years of career ahead of you, it will be a different approach than if you have an established career and you want to go back as quickly as possible. So meniscus resection is always worse in the long term, always worse than a successful repair. And this is, again, an important consideration in the young to be established athlete. So there to save the meniscus is also very important. And also be comfortable with reoperation rates, be comfortable with failures. For me, that's still a no-brainer that as a surgeon, if we go in, we take responsibility, we make choices, and you want to have the best outcome for that specific patient. So we want to reduce the failure rates, increasing the success rate of a meniscus lesion, or the success rate of repair is basically good surgery. We have tools, but they're not great. We have the PRPs, we can augment repair, but it's not ideal. So therefore, if you want to be a successful surgeon, sometimes you don't have to do the surgery. Avoid sometimes a specific repair surgery because you know that it might have a higher failure rate than acceptable. So that's also the downside and the upsides of this discussion. Thank you very much.